couple of questions, and then
Okay.
Liv, at about I think at question 5, I'm going to switch and let you take over for a while, and then that way you can get some practice interviewing.
Awesome.
Okay.
And then maybe if you want to switch back at some point, that's fine.
Great.
So, Steve, are we ready?
I'm just verifying. Yep, we are rolling. Let me sneak out of the room and we should be good to go.
All right. Well, Dr. Wakeel, thank you so much for being here with us this morning. We always like to start just by verifying if it's okay that we record this session here this morning.
Yes, absolutely.
Great, thank you so much. And then could you introduce yourself for us and spell your name for us?
Sure. My name is Fathima Wakeel, Fathima Wakeel, and I'm an associate professor at the College of Health.
Thank you so much. Could you begin just by telling us a little bit about your graduate training and your area of research specialty?
Sure, absolutely. I received my Master of Public Health at University of South Florida, and with a focus on maternal and child health. And then I received my PhD in public health at UCLA School of Public Health. And I then went to University of Wisconsin-Madison, where I'd actually completed 2 postdoctoral fellowships in health disparities research.
Thank you so much. So our first question asks you to talk about how you theorize, teach, and or write about the relationship between maternal health and population health.
Absolutely. So my research really focuses on maternal resilience, which I've conceptualized as a set of resources, conditions, and characteristics that help women reduce their exposure to stress or cope with stressors, get through stressors over the life course. So in my research on maternal resilience, I really take a life course approach. So the life course approach basically tells us that health is really not just an outcome, but it's really a process. And it's the culmination of both risk and protective factors that occur over the life course. And so this really brings us to population health, because what we've learned from maternal and child health is that the exposures that people are experiencing, early in the life course, as early as the womb and in early childhood, really have a huge impact on their long-term health outcomes. So, for example, if a child is born low birth weight, for example, after being exposed to maternal smoking in the womb, they're going to be at higher risk for chronic health illnesses such as diabetes, hypertension, heart disease later in life. So this, for example, shows us that maternal and child health approach is really key to really thinking more broadly about population health. So at the end of the day, I would say maternal health is population health, because if we can really work hard to help our mothers and children get through pregnancies and have early really healthy outcomes in early childhood, then we're really taking care of the entire population.
That's wonderful. Thank you so much. And then more specifically, obviously you and Liv and myself have been working on this project that we call the Mothers of Sierra Leone. And I'm wondering if you can talk about how you believe the Mothers of Sierra Leone project is important to larger questions of population health.
Absolutely. So the Mothers of Sierra Leone, as you know, we have been focusing on trying to improve maternal health seeking behaviors in Sierra Leone with the ultimate goal of, reducing the maternal mortality rate, right, in the country. When we look at maternal mortality in general, that's really a larger population health issue, because we know that it's rooted in these larger population health challenges. So why does maternal mortality occur, especially in a country, with limited resources? So we know it's due to things like access to health care, access to specialty care and emergency medical services, access to things like clean water, medications, vaccinations. So these are all really broader population health issues. And with our project, we know that we're really unable to address these larger determinants of health, but we do know that we can intervene at sort of the individual and maybe interpersonal and community levels to really help increase awareness and education about maternal health, behaviors and healthy, services that are available to women to hopefully increase their health-seeking behaviors, and then ultimately, work in the long term, play a role in reducing the maternal mortality rate in the country.
Now I'm going to, as often happens in these interviews, I'm going to ask you something that's mildly off the question list, but something that I know you've spoken about before, so I hope you don't throw anything at me. But I've heard you say this great line in the past, and I'd love to get it on video, where you talk specifically about an origin story. And I'm wondering if, I'm interested in thinking about that as something, I'm as a storyteller myself, I'm really interested in thinking about how we think about, the relationship between the story of maternal and child health and the story of population health. And I'm wondering if you could say a little bit more about that.
Sure, absolutely. So maternal and child health researchers and practitioners have long looked at all of the, sort of determinants of health. We've really thought a lot about, we've taken a sociological approach, and we've thought a lot about sort of what are the individual, interpersonal, community, and macro system levels that impact health. And we also have added the life course component to that. So we've added the dimension of time to that framework. So really understanding that things that occur to us even before we're born have a huge impact on our life course and our trajectory over the life course. So those theories and those ideas have sort of emerged in population health, thinking about determinants of health. But I'd say maternal health is really the origin story for population health, because we started thinking that way, earlier. And of course, I'm biased because I'm a maternal and child health researcher. But we definitely just understanding, dyads and understanding mothers and children and families, those relationships, understanding that we have linked lives, for example, that whatever mothers do directly impact children, and whatever happens to the communities directly impacting families. All of that was really, coming from that maternal and child health space. And that's really the framework that we use. One of the big frameworks we use in population health is the socio-ecological framework, is really thinking about determinants of health as well as interventions to impact health.
Yeah. I mean, I love this so much because it makes me think of of myth or anthropology of, how we think about the origin story of a population, how we think about the etiology of where people come from, and if the maternal health is not strong, if the maternal health is not resilient, if it's not healthy, then that origin story struggles.
Absolutely.
And I think that there's a fascinating sort of anthropological element there that I think is worth considering.
Absolutely.
So just questions that I know that we've dealt with a bunch, and just wanted to get some quick comments from you on the role or the importance of family planning in terms of population health. My sense is this is huge.
Of course, absolutely. So family planning is key because it really allows families or parents to determine if, when, and how often they want to have children, right? And that plays a huge role in everyone's life trajectories, including both the parents as well as, the child, if there is a child. And so, for example, when you look at women's trajectories, childbearing can play a huge role on, for example, her education and employment trajectories. So if a woman, for example, is able to sort of delay childbearing in order to get an education, and that's really going to open up her trajectories to get better job, for example, and to also have a higher socioeconomic status, which we know is then inextricably linked to health outcomes, right, over the life course. So just really providing that agency, family planning really provides agency to women to really kind of play a role in determining what they want their trajectory to look like over the life course.
Yeah. I love the way you talk about that in terms of agency. I mean, I think so often we think about family planning in terms of a physical body. Right, and we should, right? I mean, we should. But if I'm understanding your comment correctly, Dr. Wakeel, you seem to be thinking more, definitely physical body, but more than that, a larger trajectory of a family, a life, a community.
Exactly. And also, for example, with family planning, we can also think about child health outcomes. Mm-hmm. So if families are able to plan out their sort of childbearing trajectory, we can think about that increases the number of resources each child might have, for example, in a family. It's going to improve the opportunities everyone has for better health if people are able to sort of plan out and, have a role in, preparing for, having children, as opposed to, having a child when they're not necessarily ready for one.
Yeah, I mean, I think that's so helpful. The question that I know is really important to me, just because I've learned so much about this from you. Can you discuss a bit about the importance of community or the experience of community to maternal health?
Absolutely. So just like anything in population health, maternal health, we really can't do anything without partnering with the community. So if we don't partner with the community, how do we really know what the priorities within the community are? And how do we know what the opportunities are and what are the sort of strengths that each community has to offer? So we can sort of learn everything we can academically, but in order to really understand the determinants of health, we really need to talk to community members to really learn why are things the way they are? What are some of the sort of precursors that led to certain outcomes we see in the community? And also really talking to them about in terms of intervention. So unless we work with community, we're not really going to be able to design interventions that really are specifically tailored for those communities that are going to work in those communities. So it's important to work with communities to make sure, for example, we're not duplicating existing efforts, that we're not alienating important, stakeholders in the process, and just to make sure that, again, the community is playing actually a leadership role. And I'd say shared ownership of this work alongside, because all of this work that we do in academic settings really means nothing unless we are able to actually implement all of this in the community setting. So I would say the community should really be the leaders, and in fact should be coming to us when they need our assistance.
I know you have taught me so much about that, and I'm so grateful, and thank you so much for that. I'm gonna switch spots here with Liv and let her take over.
Okay, so this is kind of leading into the work that we're doing over the summer. Would you mind talking about the specific challenges and also the opportunities of rural maternal care?
Absolutely. So I have worked in rural settings in the past. I'm not globally though, but I think some of the sort of challenges are universal in rural settings. And some of them a big one is really access to care, specifically specialty care. So when you think of women and pregnancy, really women with high-risk pregnancies are going to have, a really difficult time getting the care that they need in rural settings. For example, even access to, emergency C-sections and things like that. That's really going to be a challenge in some of the rural settings. And I've even seen somewhere in global, I've heard about in some global rural settings that sometimes women are sort of kind of compelled to do an elective C-section because that's the only way they can sort of get medical care when it's planned ahead of time, as opposed to, actually needing a C-section. And we know that having a C-section has a lot of, risks for, maternal and child health, especially if it's not needed. So that's one, so access to care, especially specialty care. Along with that, I would just say, access to mental health is another big issue. And so, so that includes the entire population. But really, when you're thinking about women, we know that, pregnancy is a vulnerable state, and especially the postpartum period is a vulnerable state. And we call that the fourth trimester, the 3 months after pregnancy. So women are really vulnerable during that time, and are at risk for things like postpartum depression and postpartum psychosis. So in rural care settings, we really don't have that infrastructure for obtaining, postpartum mental health care. Along with that, I would say, along with the access to care, really that shortage of physicians, especially specialty care physicians, are not really available in rural care settings. But I would say some of the opportunities especially that I've seen here, in the United States and might be also replicated in other settings, are things like increased use of telehealth, for example, to reach, populations, the use of mobile health clinics to go to the community where they are. That's definitely been increasingly used. And just from an environmental perspective, rural settings do have better air quality, for example, less crowding, less noise pollution. So it's definitely health benefits. I would say more space, to living in rural environments. But we also have to think about sort of those unique challenges that are faced by the residents there.
Right, that's awesome. That's so interesting. I look forward to learning more about that.